I am J L Teboul from Paris. I am very honored to participate in this EasyCam 2020 virtual meeting. And I will try in the next minutes to explain why I like the expiratory occlusion test and tidal volume challenge. This slide presents my conflicts of interest. As you know, when we speak about fluid responsiveness, we speak about prediction of fluid responsiveness. And nowadays, international societies recommend using dynamic over static variables to predict fluid responsiveness when applicable. But what is a dynamic variable? It is something which can quantify the slope of the Frank-Starling curve at the time you decide to give a treatment to your patients. And we have, in fact, two categories of dynamic indices. We have heart-lung interaction indices and we have passive leg-raising test. And today I will not speak about passive leg-raising test. I will concentrate on heart-lung interaction indices, and namely expiratory occlusion test and tidal volume challenge. But when we speak about heart-lung interaction indices, we know that the idea behind is that the more the stroke volume or the cardiac output changes with mechanical ventilation, the more likely the patient's heart is pretty responsive. As you know, the most popular indices are those related to respiratory variation of stroke volume during mechanical ventilation, pulse pressure variation PPV or stroke volume variation SVV. As you know, PPV or high PPV, pulse pressure, as you know, is the difference between systolic and diastolic pressure. The high PPV is generally related to preload responsiveness, and if the patient has a high PPV, it will respond to fluid administration. And a low PPV is generally related to preload unresponsiveness, and the patient will not respond to fluid administration. Unfortunately, in patients hospitalized in the ICU, there are many limitations to use pulse pressure variation or to stroke volume variation at the bedside, because we have some cases of false negative or false positive in many situations. This is why other tests have been proposed, and for example, the expiratory occlusion test. The principle is that during each mechanical insufflation, you have a decrease in venous return and preload. So if you interrupt the ventilator at the end of expiration for 15 seconds, for example, you should have a transient increase in venous return and preload. This increase in preload will result in increase in stroke volume only in case of preload responsiveness, and no increase in stroke volume in case of preload unresponsiveness. Therefore, we can hypothesize that fluid responders can be identified by an increase in the cardiac output during the expiratory occlusion test. What are the reasons are like the expiratory occlusion test? First, because it works, of course. This is the first study we published years ago with Xavier Monet and others in our institutions, and we measure cardiac output using the pulse contour method with a PICO device, and we gave volume to patients, and we separated between responders and non-responders to fluid administration. But before giving fluids, we performed the expiratory occlusion test. And as you can observe, patients who increased their cardiac output during the test also increased their cardiac output after a fluid challenge. And patients who did not increase cardiac output during the test were fluid non-responders. So it is very easy to do. And this was confirmed by many other studies. This is a meta-analysis recently published in Annals of Intensive Care with Dr. Francesco Gavelli, Ruishi, and Xavier Monet, and others. We pulled all the studies that address the issue of fluid responsiveness using the expiratory occlusion test. As you can observe, there are 13 studies, more than 500 tests, and the OROC curve, the area under the ROC curve, was good, 0.91, with a good sensitivity and good specificity. And the average cutoff value was around 5%. So it works. And also it works even in cases of inspiratory efforts during mechanical ventilation. In the study I already talked about, we had a subgroup of patients, of 23 patients, with mechanical ventilation and spontaneous breathing activity. As you can observe, the area under the ROC curve for the expiratory occlusion test was excellent, 0.97, far larger than the ROC curve for PPV, which was only 0.68. So it works also in patients with mechanical ventilation and spontaneous breathing activity. Also, it works even in cases of low lung compliance, ARDS, for example. And this is another study published 8 years ago with Xavier Monet and others, and we looked at patients with low respiratory system compliance, lower than 30 ml per centimeters of water. As you can observe, the area under the ROC curve for the prediction of responsiveness for PPV was not very good, 0.69, but the area under the ROC curve for the end expiratory occlusion test and the effects were assessed by cardiac output was excellent, 0.97. So it works also in patients with low compliance of the respiratory system. Also, I like this test because it works even in cases of low tidal volume. And this is an additional analysis of the meta-analysis I spoke about before. And we separated in patients with low VT, less than 7 ml per kilogram, and high VT, higher than 7. As you can observe, the area under the ROC curves for both were excellent, 0.96 for low VT and 89 for high VT. So it works in any case. Also, because it works independently of the level of PEEP, this is another study we performed with Dr. Silva, Dr. Xavier Monet, and co-workers. And in the same patients, we applied 2 levels of PEEP, a low PEEP, 5 centiliters of water, and a higher PEEP, around 14 centiliters of water. And we looked at the effect of end expiratory occlusion test, and after we gave fluids to patients, as you can observe, the area under the ROC curves for low PEEP as well as for high PEEP were excellent. So we can predict responsiveness independently of the level of PEEP using this end expiratory occlusion test. And finally, I like this test simply because it is very easy to perform. You have just to press a button for 50 seconds exactly as you measure intrinsic PEEP. But in this case, you should press the button for longer time, at least 15 seconds. But it is very, very easy to do at the bedside. Of course, as always, we have limitations to use this test, and the patient should not interrupt the test by triggering the ventilator due to violent inspiratory efforts. And this may happen in 22% of cases, as we reported in this previous paper. Another limitation is that you should use a very precise and real-time cardiac output measurement. Very important. Why? Because in the meta-analysis I already talked about, the cutoff value found in these studies is around 5%. 5% is very low, so you should use a very precise technique to measure cardiac output. And for example, this threshold is not compatible with method having a poor precision. For example, echocardiography, since the least significant change for velocity time integral VTI is around 10%. So it's not possible to use this test using this technique. And this is why with Mathieu Josiac, Xavier Monet, and others, we propose to combine the effect of end expiratory occlusion on cardiac output and the effect on an inspiratory occlusion on cardiac output using echocardiography. And now, when we added the results in absolute values, we found a cutoff value of 13%, and 13% now is more compatible with the precision of echocardiography. Because, as I said, the least significant change is around 10% for velocity time integral. So if you use echo, you should combine the 2 tests. What about tidal volume challenge? It is another test to predict responsiveness. As you know, pulse pressure variation cannot be used in patients with low tidal volume, essentially because of the presence of false negative. And this is well confirmed in this study by Laurent Muller and co-workers. They subdivided patients into groups, responders and non-responders, according to the response of cardiac output to fluid administration, but before they measure pulse pressure variation. And there are many situations where PPV is low, while the patient is full responder in terms of increasing cardiac output. So there is a low sensitivity of PPV during low tidal volume ventilation. And this is why with Sheila Mayatra from Mumbai and other colleagues from India, we proposed a new test, which is called the tidal volume challenge, which consists in increasing tidal volume transiently for 1 minute only from 6 ml to 8 ml per kilogram. And now, when you measure PPV, the area under the ROC curve for PPV 8 is far better than for PPV 6, but what was far better was the change in PPV from 6 to 8 ml per kilogram, and we found a cutoff value of 3.5%. For example, if you have a PPV of 7%, you increase tidal volume from 6 to 8 ml per kilogram, and now if PPV is around 11% or 12%, you can assume that the patient will respond to fluid administration. If PPV increases from 7% to 9%, you can assume that the patient will not respond to fluid administration. So it is very easy, very simple to do. And our results were confirmed by this study by Antonio Messina and the group of Maurizio Cecconi from Italy. But they performed this study in the operating room, and they measured baseline PPV, but also baseline SVVs for volume variation. And after, they increased tidal volume from 6 ml per kilogram to 8 ml per kilogram. And now, as you can observe, the delta PPV and the delta SVV were far better predictors of fluid responsiveness than the baseline PPV and the baseline SVV. I like the tidal volume challenge because it seems to work well in cases of low tidal volume, because it is very easy to perform, and because it only requires an internal line. There is no need of cardiac output monitoring device. And in my experience, I have found that it is very useful during the COVID-19 pandemic in patients with severe ARDS, who are ventilated with low tidal volume and who generally require high-dose sedative drugs. So my conclusion, I like both the end-expert occlusion test and the tidal volume challenge because they are very helpful to overcome important limitations of PPV to predict responsiveness, and because they are very easy to perform in patients receiving mechanical ventilation.